Just to follow up on what Senator Kane said, because if obviously the program is being used as it is to be used to help those lower income folks, that's a good thing. But I do want to quote a New England Journal of Medicine article in which NYU researchers found that if you look at the provision of cancer care at a 340B program versus a non-340B program, there's actually fewer lower income patients in that cancer care. So the 340B program, which ostensibly is getting this discount to provide more services, statistically is associated with providing fewer services. And there's no significant difference in hospital provision of safety net or inpatient care for low-income groups or in mortality among the low-income residents of the hospital's local service area. If you will, it is an indictment, because theoretically this is supposed to, I worked in a 340B hospital. Some of them are fantastic. And there are patients at the poor folks hospital, if you will, where I worked, that only got medicine because of this program. But it does seem as if there's some issues with how it's currently being done. In fact, I noticed that consumer groups are advocating for it. Let me just point out something else. Last week, Memorial Sloan Kettering's drug pricing lab reported research or made the suggestion that should 340B hospitals be required to provide charity care totaling just 1% of their patient revenue, 9% of 340B hospitals would no longer be eligible for 340B. That is if they provided just 1% of their revenue for charity care. Secondly, I'll point out that if you say that the way the business model works is that the more expensive the drug, the greater the discount. If the hospital is not returning that discount to the payor, to the patient or to the federal government, they get a bigger spread with a more expensive drug. Now, Ms. Maxwell, I think I've seen evidence that, that the incentive is for the 340B program to use the more expensive medicine, because, again, that increases their spread. Is that reasonable, and do you agree with that?
You know, the work of the IG has not touched on that particular issue. Our focus has been primarily on...
Let me ask Dr. Draper. Dr.
Absolutely.
Draper. We had done a report in 2015 that looked at Medicare Part B drugs and the 340B program. And in that work, we found that the 340B DSH hospitals were generally larger, often teaching hospitals. They tended to have a lower overall margins but higher Medicare margins. And we also found that Medicare Part B spending at those hospitals was substantially higher than non-DSH hospitals. So it suggests...
So Medicare Part B, so the interaction between that and 340B is that 340B would cover the infusion drugs given on a Medicare Part B billing, correct?
Yes, if it's an outpatient drug.
And so it is so when you say that the differential is higher, it implies at least that they are using more expensive services or greater intensity of services for whatever reason, and that would include potentially using more expensive medications.
Well, it suggests that there may be some financial incentives, unintended incentives for prescribing patterns.
Now, thank you. You also mentioned that 340B entities tend to be larger hospitals. Last week, researchers from Yale, Penn, Carnegie Mellon, and MIT published a paper that found, among other things, prices at monopoly hospitals are 12% higher than in markets with 4 or more rivals. Does the current structure of the 340B program incentivize consolidation?
We really haven't done work on that, so I can't really address that. I can tell you that another one of our reports that are coming out this summer is looking, comparing characteristics of 340B hospitals to non-340B hospitals, and also looking at how those characteristics have changed pre and post healthcare reform.
Okay, so that report is pending.
Yes,
okay.
that will be coming out this summer.
Okay, and then in 2014, OIG published a report that provided a useful insight into where the benefits of the 340B discounts were flowing. The agency found that few of the hospitals you surveyed, this is for you, Ms. Maxwell, few hospitals said they passed the 340B discount back to the uninsured patient. These are the ones that, it's not Blue Cross, it is the uninsured patient who can hardly afford their medicine, the person on insulin, for example, filling prescriptions at the hospital's contract pharmacy. Given that in the intervening 3 years, no new guidance or regulation with the goal that the patients are the true beneficiaries of the program has been issued, do you have any reason to believe that hospitals have begun to pass these savings back to the uninsured?
We worked closely with HRSA and let them know about these situations, so they were able to address them as they thought appropriate. I don't know whether HRSA did in fact reach out and talk to these hospitals about their current policies.
So you have no indication either way that hospitals have begun to pass it back to the uninsured or that they have not?
That's correct.
Okay. I yield back. Thank you.